Welcome to this St Göran Lecture number 64. We are welcoming David Horrobin. He's really a very special guest. He has trained on at least 3 continents and he's constantly moving over all 5. As you know, he's present in Nova Scotia in Canada and started his medical training in Oxford in England. And maybe, were you at the Air Force in Nairobi? I've heard some...
I worked for the Flying Doctor.
You worked for the Flying Doctor in Nairobi in Africa. And at the same time you were chairman of the Department of Physiology, and then you moved to Newcastle upon time. And then 7 years ago you moved to Canada and worked in Montreal, and as I mentioned, presently in Nova Scotia. You have your base camp, but you have many different fields you are expert in, and as you know, more than 200 scientific publications. And among the other tasks, you're editor of Prostaglandins and Medicine, and the very interesting journal Medical Hypothesis, where lots of new findings appear before there are substantial data. Today we are going to get a presentation about prostaglandins, and of course a lot of basic work has been done here in Stockholm with experts. We have Erik Engel in the audience, and I'm sure there are several others. Now the question is, what does this mean for clinical psychiatry? And the field may be moving in 2 directions. One, to find out more about prostaglandins biochemistry, and at the same time to find what are the prostaglandins doing, particularly in the brain. And I guess there are a few persons that can really grasp and put this together. And we are very much looking forward to hear your new hypothesis, how you explain alcoholism, schizophrenia, maybe depression and other mental diseases, with hypothesis from prostaglandin to David Horrobin.
Well, thank you very much. I'm very pleased to be here this afternoon. What I would really like to do is to try to persuade you that the prostaglandins and also the essential fatty acids from which the prostaglandins are derived are substances which anyone who is interested in brain function at a neurobiological level or at a psychiatric level should be beginning to take seriously. I don't think I would claim to try to persuade you anything more than that at this stage. I would like to try to persuade you that if you are interested in neurobiology or in psychiatry, you should be beginning to think about essential fatty acids and prostaglandins. There are a number of basic reasons why one should think about essential fatty acids and prostaglandins. The brain is 55–60% lipid as far as the solid matter is concerned, and something like 20% of that lipid is essential fatty acid. So from a structural point of view, there is a great deal of essential fatty acid in brain tissue. Secondly, if you take prostaglandins and inject them in small amounts into the cerebrospinal fluid, you get quite dramatic behavioral changes in the animals. If you look at Erik Horton's papers, which were published in the mid-60s on the injection of various prostaglandins into the cerebrospinal fluid of animals, you will see that the pictures are just as dramatic as those one gets after injecting endorphins and enkephalins into cerebrospinal fluid. But for some reason, while the papers on the endorphins and enkephalins attracted an enormous amount of attention, Erik Horton's early work just didn't stimulate the sort of interest which the endorphin enkephalin stuff did, and as a result, relatively few people have been working on prostaglandins in the nervous system. However, it is quite clear from the work of those few people that prostaglandins have profound effects on the velocity of nerve conduction, on the amplitude of action potentials, on the amounts of neurotransmitters released at nerve endings, and on the postsynaptic actions of transmitters. Now, quite clearly that doesn't prove anything at all, except that when one has substances which have that sort of range of actions, one ought to be saying, well, maybe these are playing some key role in neurobiology and possibly in psychiatry. Many of you will be familiar with the essential fatty acid pathway. Some of you will not, and so the first slide outlines that pathway. We take linoleic acid in the food. The linoleic acid is converted to gamma-linolenic acid, or GLA. The GLA is converted to dihomogamma-linolenic acid, or DGLA, and that is the precursor of the group of prostaglandins known as the 1 series, which have one double bond in one of the side chains. DG1 is a typical example of this series. DGLA converted to arachidonic acid, which is the precursor of the 2 series prostaglandins, and not shown on here, arachidonic acid can be elongated and converted to a number of essential fatty acids which are extremely abundant in cerebral tissue. So pathway starts with linoleic acid and ends up with the longer chain acids beyond arachidonic acid. As you can see from this slide, this was prepared for another purpose. There are large species variations in this pathway. And one of the problems with the prostaglandin field is that there is, in a sense, a division between the people who work on essential fatty acids and the people who work on prostaglandins, and almost never the twain shall meet. And the people who work on essential fatty acids tend to be ignorant of what's happening in the prostaglandin field, and vice versa. And one of the things that a lot of prostaglandin people don't appreciate are the species differences in essential fatty acid metabolism. As you can see, this enzyme is certainly totally absent in cats, and that's all the cat family, domestic cats, lions, tigers, and so on. This enzyme is probably absent in cats. In rats, which are of course the standard laboratory animal, both these enzymes are highly active, and linoleic acid is very rapidly converted to arachidonic acid. And certainly in rats, the arachidonic acid and the 2 series prostaglandins derived from them are of very large importance. In humans, however, the pathway seems to be somewhat different. And this work was first done by Jim Willis when he was working with Roche and now works in Syntex. And he was the first to point out that this enzyme, which converts DGLA to arachidonic acid, seems to have very little activity in humans after puberty. He's fed large amounts of DGLA to humans and found very little conversion to arachidonic acid. And it seems increasingly as though we actually get a lot of arachidonic acid also from the diet. There are quite large amounts of arachidonic acid in meat, and it's probable that this plays a particular role in humans. Now, alcohol, it's beginning to be clear, has very substantial effects on this pathway. And it has effects on the pathway at 2 different points. First of all, alcohol inhibits the enzyme, the delta-6 desaturase, which converts linoleic acid to gamma-linolenic acid. And as a consequence of that, I think the count is now 6 different groups working in South America, the United States, and Britain, have demonstrated that a high dose of alcohol leads to a deficit of the essential fatty acids beyond this point. And it's also been shown that if you administer essential fatty acids beyond this point, you can, for example, in animals treated with alcohol, prevent the development of fatty liver. Fatty liver does not develop in alcohol-treated animals which are given a fatty acid beyond this step. The fetal alcohol syndrome, the damage to the fetus produced by alcohol, does not happen if the animals are simultaneously treated with gamma-linolenic acid, which bypasses this block step. And so there's beginning to be quite a lot of interest in the idea that a lot of the pathological consequences of alcohol action relate to the production of essential fatty acid deficiency as a result of interference with essential fatty acid metabolism. That's, however, not the only part of the story, because alcohol also seems to specifically activate this step, the conversion of dihomogamma-linolenic acid, or DGLA, to one series prostaglandins. 2 groups have now shown this, our own group and a group headed by John Rotrosen at New York University Department of Psychiatry. And so alcohol has a peculiar double effect on essential fatty acid metabolism. It activates this step here, and therefore will lead to a depletion of available DGLA precursor. At the same time, it blocks that step and so prevents the replenishment of the DGLA which is used up by activation of this step. Now, a lot of prostaglandin people don't believe that this step is relatively non-functional in human beings. Where's the... So I thought I'd show the results of a study which we've just carried out in a group of hypertensive humans, in which we administered gamma-linolenic acid, the second fatty acid in the pathway, and measured changes in DGLA and arachidonic acid over a period of 6 weeks. And as you can see, the DGLA level, assuming the starting level was 100%, rose 6 to 7-fold over a 6-week period in the plasma, whereas the arachidonic acid only showed a 50% rise in the plasma. In the platelets, there was a similar difference, with platelet DGLA rising 4-fold, whereas platelet arachidonic acid rising only 17%. And what this does is really simply confirm the work that Jim Willis did, in that humans who are beyond puberty seem not to convert DGLA to arachidonic acid very effectively. And this means that one has the potential for selectively manipulating the precursors of the 1 and the 2 series prostaglandins, because one can feed arachidonic acid directly by changing meat intake. One can change the DGLA by changing the intake of vegetable oils or of gamma-linolenic acid. So I think it's important to appreciate that humans are not rats, that one has to be very cautious about extrapolating from rat experiments to humans in the prostaglandin essential fatty acid field. This is one of our studies in which we incubated human platelets with either arachidonic acid or DGLA and looked at their conversion to prostaglandin metabolites. And we looked at their conversion in the presence of different concentrations of ethanol which I won't say are physiological, but certainly are clinically relevant, the concentration range which is present in humans during intoxication. As you can see, we have really a very specific effect of alcohol on the conversion of DGLA to its one series prostaglandins, with no effect on the conversion of alcohol and the conversion of arachidonic acid to its series of prostaglandins. And this work is very, very similar indeed to similar work done by John Rotrosen in New York and done quite independently of our studies. Now, John Rotrosen at New York University has become particularly interested in the effects of alcohol on prostaglandin and essential fatty acid metabolism. And in particular, he's been exploring the hypothesis that the acute effects of alcohol relate to stimulation of prostaglandin E1 production, and that the withdrawal of alcohol relates to a catastrophic fall in prostaglandin E1 production, occurring as a result of depletion of the availability of the precursor of the prostaglandin E1 and removal of the stimulation. And so his hypothesis is that the acute effects of alcohol relate to stimulation of prostaglandin E1 production, and that the withdrawal from alcohol may relate to a catastrophic fall in prostaglandin E1 production. And these are some studies which he recently carried out, in which he was working with mice this time and using sleep time as an indicator of the acute effect of alcohol. Mice are quite nice from this point of view, because when you give them alcohol they go to sleep, and the duration of sleep time can be very easily measured. He showed that olive oil, which is an oil which is similar to many essential fatty acid containing oils, but which doesn't contain essential fatty acids, had no effect on sleep time. Not shown here, he was able to show that PGE1 produced sleep by itself, and when the PGE1 was given with alcohol, he got an enhancement of the alcohol-induced sleep time. Here he was giving evening primrose oil, which is a mixture of linoleic and gamma-linolenic acids, and showed that giving evening primrose oil before the alcohol accentuated the effect on sleep time. Here he's giving pure gamma-linolenic acid, again showing that giving gamma-linolenic acid with the alcohol enhanced the effect on sleep time. Here he's given aspirin, which blocks the conversion of essential fatty acids to prostaglandins, and shows that aspirin alone interferes with the effect of alcohol on sleep, that the animals do not sleep anything like so long when they're given aspirin before. And here showing that the effect of the primrose oil, which the primrose oil alone is here, is substantially attenuated if the primrose oil is given with the aspirin. And from these experiments he concludes that at least some of the acute effects of alcohol are related to stimulation of prostaglandin biosynthesis. He then went on to have a look at the alcohol withdrawal, and there the prediction would be that during consumption of alcohol, prostaglandin production is enhanced, but that on withdrawal from alcohol there is a very sharp fall in the formation of prostaglandin because of depletion of the essential fatty acid stores. The model he was using was a vapor chamber in which all the animals were exposed to ethanol-containing vapor. This is a nice model because it means that by switching off the vapor you can produce an abrupt time at which the animals are stopped being exposed to alcohol. And therefore, unlike feeding experiments, you can have a situation where all the animals in a group cease to be exposed to alcohol at the same time. And after stopping the alcohol, the animals go and develop various neurological symptoms, twitching, fitting, and so on, which are scored in a fairly elaborate way. and the withdrawal syndrome intensity increases and reaches a maximum at 10 hours after withdrawal. And what he and his colleagues did was to see what other agents might be able to prevent the withdrawal syndrome. Here is the control situation where he's given saline. Here he's giving evening primrose oil, which will replenish the essential fatty acids theoretically depleted by alcohol, and he gets a substantial attenuation of withdrawal. And here he shows that aspirin reduces the effect of evening primrose oil on attenuating withdrawal. Here he's using prostaglandin E1 itself, shows that prostaglandin E1 produces a highly significant inhibition of withdrawal syndrome, but that unlike the effect of primrose oil, the precursor of prostaglandins, the effect of PGE1 is not influenced by aspirin, which blocks prostaglandin E1 synthesis. One would not expect aspirin to interfere with the action of PGE1, since the PGE1 is beyond the point at which aspirin acts. I won't go over in detail the bottom row of experiments, but essentially what he was able to show is that prostaglandin precursors will attenuate the withdrawal syndrome, that this seems to be associated with an increased prostaglandin production because the attenuation can be blocked by drugs which interfere with prostaglandin synthesis. And he went on to investigate a whole series of other drugs. He also showed, interestingly, that linoleic acid, which is the first fatty acid in the pathway, had no effect on alcohol withdrawal. And that is important. I don't know if we can go back. Because if you remember the pathway, a number of groups of workers have shown that alcohol blocks this step. So he was able to show that gamma-linolenic acid was able to block alcohol withdrawal, but linoleic acid, which comes before the alcohol block step, was totally ineffective in blocking alcohol withdrawal. And so his experiments are certainly consistent with the hypothesis that some of the effects of alcohol are associated, on the one hand, with stimulation of conversion of essential fatty acids to prostaglandins, and on the other, with a blockade of the essential fatty acid pathway at the first step. Now, the first paper, as far as I am aware, of prostaglandins specifically in relation to psychiatry was published by a group from Guy's Hospital Medical School in London in the British Journal of Psychiatry in 1975. And what they did was to take human platelets and look at the ability of those platelets to make prostaglandin E1 from its precursor in the presence of various concentrations of ADP, which are known to stimulate prostaglandin E1 production. These are the numbers of patients in each group, and the values shown here are the full range of values found. They're not standard errors or standard deviations, they're total ranges. And at a half maximal concentration of ADP, he found that this was the normal range of prostaglandin E1 production. He found that a group of 8 manic patients produced a significantly increased amount of prostaglandin E1, that a group of 10 depressed patients produced a significantly reduced amount of prostaglandin E1, and a group of 20 schizophrenics who had been off treatment for at least 3 weeks produced virtually no prostaglandin E1 at all. When he switched to a maximal concentration of ADP, the differences between the normals and the manics and the depressed individuals disappeared, but the schizophrenics still stayed down here. And the difference between the schizophrenics and the non-schizophrenics was significant at p less than 10 to the minus 7. As far as I'm aware, it's the most statistically significant observation in biological psychiatry, with the difference between the top schizophrenic and the lowest non-schizophrenic being more than 8 times the range of values within either group. So that's a paper which was published in 1975 and, like Horton's work, attracted no attention and no interest. A little before that, I'd begun to be interested in the prostaglandins for quite a different reason. I was interested in the hormone prolactin and interested in its effects on fluid and electrolyte balance. And in a series of studies, I and a group of colleagues injected prolactin into ourselves. And we found that prolactin did have some effects on fluid and electrolyte balance, but to our considerable surprise, we all experienced mood changes with the prolactin injections. And the prolactin was injected on a blind basis, so we didn't know whether we were getting saline or prolactin. We kept diaries of what was happening and found that for 24 to 48 hours after prolactin injections, we experienced a number of mood changes, depression, irritability, and so on. And this made me interested in the idea that prolactin might be a psychotropic hormone. Now, the reason why this is interesting is that prolactin is stimulated, the secretion of prolactin is stimulated by every anti-schizophrenic drug in use. And the consistency of the effect of anti-schizophrenic drugs on prolactin is such that most drug companies now use this as their primary screening test for an anti-schizophrenic action. The reason that the anti-schizophrenic drugs stimulate prolactin secretion is that the drugs block dopamine receptors, that dopamine inhibits prolactin production, and therefore if you block dopamine receptors, you will get an increase in prolactin secretion. So we have a sequence of events which invariably occurs when you administer an anti-schizophrenic drug: dopamine blockade, prolactin stimulation. Now, in fact, there is no logical reason at all why one has to assume that it's the dopamine blockade rather than the prolactin secretion which is producing the antipsychotic effect. Logically, the evidence is equally consistent with either hypothesis. All the drugs produce dopamine blockade, all the drugs produce prolactin secretion, and there is really no independent evidence which allows one to decide which of these two effects is producing the biological response. And I was interested in the idea that prolactin therefore might be an anti-schizophrenic agent. And we set about trying to find out how prolactin might work, and in a series of experiments which I've got on some later slides, but I don't think I'll go over in detail because the time is not long enough, we came to the conclusion that in vascular tissue, at any rate, which was the model we were using, prolactin worked by increasing the production of prostaglandin E1. It seemed to increase the output of one series prostaglandins without changing the output of two series prostaglandins. So naturally, I was extremely interested in this observation of Abdullah and Hamada that schizophrenics had a low level of prostaglandin E1 production in their platelets, because we had produced evidence that prolactin was able to stimulate prostaglandin E1, and therefore that in someone treated with a schizophrenic drug, an anti-schizophrenic drug, one would anticipate that the sequence would be dopamine blockade, prolactin secretion, prostaglandin E1 production. And here were a group of schizophrenics who seemed to be profoundly deficient in their ability to make prostaglandin E1. At the same time, digressing a little, we found that prolactin seemed to be acting at this point. It seemed to be influencing the conversion of esterified phospholipids to free dihomogamma linolenic acid, and therefore enhancing the formation of prostaglandin E1. And at the same time, we were able to demonstrate that lithium ions over a concentration range from 0.2 to 2 millimolar which is again a clinically relevant concentration range, was able to stop this effect. So lithium ions were able to interfere with the mobilization of dihomo-gamma-linolenic acid. And this begins to make one wonder whether in fact there's not something very interesting about this substance, prostaglandin E1, in relation to mood. Some of you will be aware that there are a lot of people at the moment giving prostaglandin E1 infusions to people who have vasospasm. Because prostaglandin E1 is a very powerful peripheral dilator. And they're also giving prostacyclin infusions. Now, prostacyclin is also a very powerful vasodilator, but is derived from arachidonic acid. And both these substances are effective in relieving the... Do you want me to stop while you're... Okay. Both these substances are effective in relieving the vasospasm. But if you talk to the clinicians who are doing the infusions, they report something very interesting indeed, which is that the patients given infusions of prostaglandin E1 tend to become euphoric, and occasionally they become frankly manic. Now, the obvious conclusion one would say is, well, this is obviously a secondary consequence of the vasodilatation. These people have got very severe vasoconstriction, so they're happy that their vasoconstriction is relieved and they feel better. But prostacyclin produces exactly the same degree of vasodilatation, and yet the patients don't like it. They don't want prostacyclin infusions. They get dysphoric during the infusions of prostacyclin. So that makes one wonder whether or not prostaglandin E1 doesn't have some very interesting effect on mood. The other evidence pointing in the same direction is that prostaglandin E1 is produced by alcohol, and the low concentrations of alcohol will increase the formation of prostaglandin E1. Now, obviously, low concentrations of alcohol tend to produce an elevation of mood. You may remember that at half maximal ADP concentrations, Abdullah and Hamada showed that platelets from manic individuals, who also have an elevation of mood, were producing significantly elevated amounts of prostaglandin E1. And now we have a demonstration that lithium is able to reduce the production of prostaglandin E1. And of course, lithium is effective in the treatment of mania. This raises, again, a side issue, an interesting potential hypothesis for mania. Suppose that prostaglandin E1 is a mood regulator, and suppose that the key defect in mania is a failure of regulation of this pathway. That during the manic phase, there is rapid conversion of essential fatty acid precursors to prostaglandin E1, and this produces an elevation of mood. The precursor supplies are limited, and there will come a point when they fall below a critical level, and as a result there will be a catastrophic fall in prostaglandin production. This, if prostaglandin E1 is a regulator of mood, will lead to depression. Lithium would work by preventing the excessive mobilization of prostaglandin E1. As a result, it would prevent the manic phase and would actually have a therapeutic effect in the manic phase. It would have no therapeutic effect in the depressive phase because there the stores would already be depleted and there would be no inhibition of conversion. But it would prevent both the manic and the depressive phases by preventing the excessive depletion and therefore the subsequent fall in prostaglandin E1 levels. Now, obviously that's only a hypothesis, but it's a hypothesis which does explain a number of features of manic depressive psychosis and of the nature of the action of lithium. Now, in the last 10 minutes or so, I'd like to go back to Abdullah and Hamada's findings on prostaglandin E1 production. And these are their actual findings in the 20 schizophrenics, and show the change in prostaglandin E1 levels with increasing concentrations of ADP in the incubation medium. These are the changes in their 8 manic individuals, and the pattern was very similar in their depressed individuals and their normal individuals. The actual curve was different at this level, but the overall pattern was rather similar. A substantial rise in prostaglandin E1 production as the concentration of ADP increases. No change in prostaglandin E1 production as ADP increases in the schizophrenics. And so this leads to the idea that possibly there is a lack of prostaglandin E1 in schizophrenics. Indirect evidence pointing in the same direction would be our work on prolactin and its effect on prostaglandin E1, but clearly that's very indirect. About 3 years ago, a number of people began to be stimulated to look at other aspects of this system. And Alexander Mate, who is not unknown to people in Stockholm, in New York, began to look at 2 series prostaglandins in cerebrospinal fluid from schizophrenics. And he got diametrically opposite results from Abdullah and Hamada. He showed that there was a highly statistically significant elevation of 2 series prostaglandin levels in cerebrospinal fluid from schizophrenics. So we appear to have 2 contradictory results here, with Abdullah and Hamada finding a deficit of production of 1 series prostaglandins formed from dihomo gamma, and Alexander Mate finding an excess of 2 series prostaglandins formed from arachidonic acid. And one might think that perhaps those 2 investigators have somehow got it wrong, that one of them's wrong at least, and that somehow the experiments don't work or don't fit. But then Robert Hitzeman from the University of Cincinnati recently did some work in which he decided to look at the essential fatty acid levels in red blood cells from schizophrenics. So he was looking at the precursors of the prostaglandins in red blood cell membranes. And I'm sorry I don't have a formal slide of this, but these are the results he got in red blood cell phosphatidylcholine. In normal individuals, linoleic acid made up 18.8% of the fatty acids, dihomo gamma 1.9%, arachidonic acid 5.6%. The ratio of arachidonic to linoleic was 0.3, or of arachidonic to DGLA was 2.95. So those were the normal individuals. These were a group of people who presented with a schizophrenic type psychosis, but who were later found to be lithium responsive and therefore were classed as patients with schizoaffective disorders. And the results are very similar indeed to the results in the normal individuals. Linoleic very similar, DGLA very similar, arachidonic acid very similar, and no significant difference in the ratios. But this group, who were what might be called core schizophrenics, who would be classified as schizophrenics anywhere in the world, had a dramatically different essential fatty acid pattern. Their linoleic acid level was not much more than 1/3 of the level in the other 2 groups. The DGLA level was below the limit of detection, whereas the arachidonic acid level was 2 to 3 times greater than the levels in the other groups. And the ratios of arachidonic to linoleic or arachidonic to DGLA were dramatically different from those in the normal individuals or in the schizophrenics. And of course, this fits extremely nicely with the work of both Abdullah and Hamada, who showed that there was very little PGE1 formed. Hitzeman found no PGE1 precursor, and of Alexander Mate, who found that there was an excess of 2 series prostaglandins. Hitzeman shows an excess of 2 series prostaglandin precursor. Now, how can we begin to make sense of all this? First of all, again, reviewing essential fatty acid metabolism. Up to now, I've only been talking about the so-called omega-6 series of essential fatty acids, which have their first double bond, 6 carbons from the omega end of the pathway. There is also an omega-3 series of essential fatty acids, which seems to be of usually less importance than the omega-6 series in most places, except the brain and the retina. Because in the brain and the retina, the amounts of long-chain fatty acids of the omega-3 series and the omega-6 series are very similar indeed. Summarizing the findings, what we seem to have is a situation where in the normal situation, one has rather high levels of linoleic acid, one has modest levels of DGLA, one has reasonable levels of arachidonic acid, but levels which are very much lower than the linoleic acid levels. One has low production of 1 series prostaglandins, correlating with the low levels of DGLA. One has high production of 2 series prostaglandins. And what seems to be happening is that this pathway has changed its behavior from normal individuals. If one looks at the diet, there is a lot more omega-6 essential fatty acid in the diet than omega-3 essential fatty acid. The omega-3 essential fatty acids are not particularly common in the diet. And as if to compensate for that, the affinity of the enzyme systems, which metabolize both series of essential fatty acids, seems to be such that they prefer the omega-3 series. So what happens is we end up with similar amounts of longer chain omega-3 and omega-6 fatty acids in the brain, even though we start off with much smaller amounts of omega-3 series. The pathway prefers the omega-3 series. What seems to be happening in the schizophrenics is that this omega-6 series is highly active, and we are getting very rapid conversion of linoleic acid right through to arachidonic acid, particularly activity at this step leading to a deficit of 1 series prostaglandins. Now, there are 2 other papers in the literature which again deserve attention. Again, they've been ignored. One is in the Journal of Neurology in 1979, which came from the University of Ibadan in Nigeria and was perhaps ignored because it came from Ibadan. But what that paper showed was that in schizophrenic red cells and plasma, the concentration of alpha-linolenic acid was excessively high, was very, very much higher than normal. So in schizophrenics, the concentration of alpha-linolenic acid was exceedingly high. Also, in a paper in Biological Psychiatry last year, Donald Rudin from Pennsylvania claimed that giving diets exceptionally rich in alpha-linolenic acid produced a therapeutic improvement in schizophrenics. So how can we begin to make sense of all these observations? We've got low linoleic, 0 DGLA, very low PGE1 levels, high arachidonic acid, high 2 series PGs, very high alpha-linolenic acid, and yet a clinical response to giving alpha-linolenic acid. And one possible explanation is that there has been a switch in the affinity of these 2 enzymes from the omega-3 series to the omega-6 series. So that in the schizophrenic, instead of preferring the omega-3 series and metabolizing these preferentially, they prefer the omega-6 series, so that linoleic acid is very rapidly converted to arachidonic acid, whereas alpha-linolenic acid is metabolized very slowly, leading to an accumulation of alpha-linolenic acid, but to a possible therapeutic response from giving alpha-linolenic acid. Well, that's the situation, I think, as far as observations are concerned. And I should point out that there are now 5 groups working on quite different aspects who've found abnormalities in prostaglandin or essential fatty acid metabolism or levels which are significant at better than the P001 level. And I don't think there's any other area of biological psychiatry, or certainly schizophrenia research, where one has such a group of independent observations which are so statistically significant. Now perhaps having attempted to stay within the realms of reality, one might, for the last couple of minutes, leave the realm of reality and say, okay, what's the possible explanation of all this? What's the biological basis of all this? One of the things I find interesting about schizophrenia is that although it quite clearly has a genetic basis, it is very unusual among genetically based diseases in being present at approximately similar incidences in all the races of the world. There are remarkably small differences in incidence of schizophrenia from Eskimos to Australian Aboriginals. They are differences, but they're small compared to the differences which one sees with almost any other genetic-based disease. It's also apparent that in spite of the, in particular, reproductive disadvantage of being a male schizophrenic, that the incidence of schizophrenia seems to stay remarkably constant, which suggests that while being a schizophrenic may be very bad for you, being a carrier of schizophrenia may possibly be rather good for you. If schizophrenia is present in all races, it suggests that the schizophrenic gene emerged at a time prior to the differentiation between blacks and browns and yellows and so on, i.e. it's a very, very old gene, perhaps the oldest disease gene that we have. And it must have emerged probably sometime, perhaps between 2 and 6 million years ago. What was happening to us between 2 and 6 million years ago? Well, there is an enormous gap in the fossil record during that period. We have pretty good records up to about 2 to 3 million years ago. And then the fossil record in Africa goes blank for about 4 million years. And then anthropoid or pre-anthropoid fossils begin appearing again. And during that period, Africa was essentially total desert. Africa dried up and became total desert. So where were our ancestors during that time? Alistair Hardy, who's professor of zoology at Oxford, has suggested that the only way in which our ancestors could have survived that climatic change would have been to live on the seashore. And we have many aquatic features of physiology, such as our diving reflex, our subcutaneous fat, and so on, which do suggest that we had a semi-aquatic phase of life. Characteristic of seashore diet is that it is almost deficient in omega-6 fatty acids, but excessively rich in omega-3 fatty acids. And it would therefore have been an advantage, assuming that both sorts of long-chain fatty acids are important in brain function, to have a gene which made use of the small amounts of available omega-6 fatty acids. So it would be an advantage to have the schizophrenic pattern of EFA metabolism if we were eating an exclusively marine diet. Having got over that phase, assuming that it's a relatively simple enzyme mutation with homozygous and heterozygous individuals, the heterozygotes would have a very substantial advantage, because heterozygotes who had half their enzyme in this form and half their enzyme in this form would be enabled to maintain their brain EFA concentrations irrespective of what was happening to their diet. The homozygote schizophrenic type would be at an advantage if there was an excess of omega-3 series. The homozygote normal type might have been an advantage if there was an excess of omega-6 series. But the carrier of schizophrenia, the heterozygote, would be able to cope with both situations. Now, quite clearly, that's wild speculation. However, it is testable, because we should be able to find the different enzyme affinities, if it's true. And that's what we're hoping to do over the next 3 years. Thank you very much.
Maybe you can stay for questions. May I ask you, since we have one expert